Cultural Consultation Service was established in 2010. This service provides a specialist model of care imported from Canada, where the model was first established. The model relies on anthropological understandings of culture and takes account of the patient's personal story and narrative in a way that existing clinical care doesn't accommodate. So the individual patient, for example, may have very unusual explanations for what causes their illness, what they call it even, and what might help remedy it. And the clinician wouldn't be aware of this, and there may be divergent explanations or explanatory models which lead to conflict and disengagement and perhaps a lack of treatment adherence on some occasions. And so the Cultural Consultation Service attempts to incorporate the patient's personal story and narrative in clinical decision making in a better partnership with the clinician. And so the idea is that there's a better understanding of the patient's problems in an in-depth way, and the patient's more likely to engage with particular treatment approaches. Well, culture affects the way people express mental distress, experience it, and ultimately the way we have to manage it. And part of the cultural consultation process is to assess culture very carefully, and we do this by assessing the individual's cultural identity, where they were from, how they feel about their identity, whether their identity has changed over time or not, what their explanatory models are of their illness, what they think causes the illness, what they think might remedy the illness, and also what they think the consequences of the illness is upon their health and well-being.
My name is Victor Adibawali. I'm the Chief Executive of Turning Point Health and Social Care, commonly or uncommonly known as Lord Victor Adibawali, as I'm still the Chief Executive of Turning Point Health and Social Care. Cultural consultation, if you're talking about consultation generally, I would say, you're talking about consultation to members of the BME groups or perceive themselves to be BME groups, I would say the following. One, although this might sound an odd thing to say, actually consultation with those groups has improved over the last possibly 5 to 10 years, namely because of things like Delivering Race Equality Programme, which I know that some people were critical of, but in fact it was one of the few programmes that actually reached out to the black community deliberately through the employment of people who did nothing else. And secondly, the creation of IAPT, Increased Access Psychological Therapies, which has been shown to improve access to mental health and services, certainly at the earlier stages, and for conditions like anxiety and depression. So that's the first thing I say. The second thing to say, would I say they were at the end, i.e. that would resolve something as a result of these improvements? Clearly not, given that there's been 11 deaths associated with mental health and police action, a significant number or disproportionate numbers of those have been black people, then you would indicate there's something still not quite right. It's also the case that black people perceive, and when I say black, I mean black politically, I don't just mean people look like me, by the way, that the mental health system isn't for them, that we haven't got the services right at the early intervention stage. It seems to escalate very quickly for black people, and their experiences in the system, I mean, i.e. if they are detained, aren't very good. In fact, they are pretty poor.
I'm Nicole Ascoli. I'm a consultant psychiatrist and a psychotherapist from Italy. I work for the Cultural Consultation Service and also for the NHS. During my work with the Cultural Consultation Service, I was able to collect a lot of narratives from service users and also from staff. Service users, when they belong to a culture that is not the mainstream culture, they often feel misunderstood, stereotyped. They feel that they are not being listened to. They sometimes are afraid to tell the truth to mental health professionals about what they really believe for fear of being labeled as mentally ill. The gene possession is a typical case. Very few patients have got the guts to tell the psychiatrist, I think I've got a gene possessing me, for fear of being labeled as delusional. And this still does happen sometimes.
Okay, I'm Alicia Farhan, and I'm working as an honorary graduate student at primary care in NHS service and secondary care in rehab team. At the same time, I'm doing MSc in psychological therapies from Queen Mary University. I'm from Pakistan, and where there is a lot of pressure of abiding by the cultural norms, and because of the strong family ties, if you are considered as an outgroup if you're not part of the certain cultural norms, and you have the pressure from the family as well. So as an individual, I used to feel very pressurized in some areas, but I still went on with that. But coming here, getting educated, especially in this course in cultural consultation, I've learned to acknowledge that the cultural norms are there, but I've learned to some extent detach myself from those which have a negative effect on me and adopt those which are healthy. As a therapist, cultural consultation has informed me how to interact with person on an individual level, and how to acknowledge and respect and regard the person's values and culture without questioning too much about it. And it will help eventually. It will help the patient eventually, as in getting the assurance that he's being understood. And for me as a therapist, I can also, this cultural consultation has now that it made me aware of my own culture, so I get this opportunity to do a bit of self-reflection on my practice as well, and how to put my culture separate from the other person, from the patient's culture, and how to help the person to reform some ideologies, and instead of challenging them.
My name is John Owiti. I currently work at the Center for Psychiatry as a research fellow, but also I work as a cultural consultant with the Cultural Consultation Service, which is based at the Center for Psychiatry, Queen Mary University. We have the necessary skills. We use a model which is based on narrative collection, using ethnographic interviewing techniques, talking to patients at their own level and actually looking at their needs within their own worlds. And when we realize that when we do this with the sets of questionnaires, and actually you engage with them and they lead you on, you don't actually limit the extent to which they are able to actually work with you. And when you do that, and these narratives, actually these complex narratives do emerge, and then when you're able to deconstruct them and formulate a care plan from them with the patient actively involved, actually huge gains are realized, because patients feel that they're actually being listened to. And secondly, you are able to know and learn a lot from the patient, and not dismiss their narratives, these stories they tell you, but work with that. And from that, they would engage with you. That's the things actually we did find out, that they're happy with the service that they would actually receive from you.
However, the wider political commentary about anything to do with culture, anything to do with race or ethnicity, is a real problem. It's a real problem not because it's produced by patients and people suffering distress, but it's a problem of the political and social system we live in, and the political attitudes and views of the wider society. We know that the way people adapt to their environment depends not only on their own resources and coping, but also the receptivity of the environment and receptivity of societies to accommodate their health and well-being and their needs. And we know currently there's not much leeway for accepting that race and ethnicity and racism are relevant factors in health and well-being. There's increasingly a move to censor racism, for example, as a relevant psychosocial factor, and censor the fact that race and ethnicity impinge on people's health and well-being.
For me, there's an accountability piece. If we're going to spend 120 billion quid on health and social care in this country, I want the commissioners held accountable for the fact that BME groups in some communities don't get a good service, whether it's mental health, cancer, whatever. It's like, actually, if I'm going to give you the authority to spend this money, don't, and I go and talk to my mother or, BME, and I find that nobody understands her, there's been no contact, there's been no engagement, the services don't fit, I want somebody who's in charge of that process to answer for how they've spent my tax dollar.
Many of the staff come and work with us and train with us because they see this as a need that's neglected in conventional NHS training and practice and professional training and practice. So the areas of work we're developing further is now to develop cultural consultation further, test it as an intervention more widely. We've got studies on therapeutic communications going on within which cultural consultation will be tested. We're also going to be looking at CART, a common substance that's legal in the UK and is available on the street, which is thought to have amphetamine-like properties but is illegal in other countries, and we think it has wider impact on health and well-being and is a marker of social exclusion. Again, we're going to carry on doing that work that we've been doing for a long time. Well, one of the territories we're looking at the moment is violence and radicalisation and the influence of religiosity and social exclusion and discrimination and international policy on the vulnerability of individuals to become socially excluded and extreme and participate in violent radicalisation. Again, all of this work you would think would be better supported by governments and by the authorities, but essentially I think the fact that it's linked with race and ethnicity tends to frighten people. It produces a very powerful, noxious, potential discourse that people are frightened to get involved in because they know it can be explosive, and I think in part it reflects the history of intergroup relations, interracial relations, which has always involved violence and fear and trepidation. We need a mature approach to tackle these subjects now and integrate ways of thinking across different disciplinary boundaries, not leave medicine in one place and health in another place and nursing in another place and sociology in another place, but to pull all these bodies of knowledge together to work in the best interest not only of individual patients, members of the public, but society as a whole.